Good afternoon. Hopefully everybody enjoyed the morning breakout sessions. Welcome back, and hopefully lunch was enjoyable as well. I noticed a lot of conversation out there, which is great. Without further ado, I'll introduce Dr. Schumm back up to the podium, and he can give us our afternoon keynote lecture. Help me welcome Dr. Schumm.
All right, thank you. Good to see everyone back again for the afternoon. So for this session, I'm going to focus on taking kind of a similar model and similar approach, but looking at addressing PTSD among military members and veterans. And so we're going to focus on a model of treatment that was developed by Candace Monson, Stephanie Fredman, called Cognitive Behavioral Conjoint Therapy for PTSD. So what I first want to do is start by setting this up in terms of how we think about treatment and, I guess, the focus of treatment. And we could start at a very kind of minute level in terms of treatments and understanding PTSD from a biological perspective, right? So we know there are areas of the brain that correlate with having PTSD and symptoms of PTSD. The hippocampus, we know that the hippocampus, among other areas. We know that there are certain neurotransmitters that are targeted in evidence-based interventions that are biological in nature to address PTSD. So serotonin being one of those, right? So when we take a medication, kind of that's what level we're talking about here, is at a biological level. Now, next in the circle, and I can use my pointer here. It's good use of that. So here, with this next outer circle, we can consider things like appraisals, meaning how do we think about our experiences in the following a trauma and in the context of the trauma? How has trauma impacted our view of ourselves, other people, the world? So individually based treatments that are evidence-based treatments for PTSD at an individual level target these appraisals, okay, often. So trauma processing type therapies such as cognitive processing therapy and prolonged exposure therapy, which we both know work well. They're both individually based treatments. In addition, we think about experiential avoidance. And that's a term, what we really mean by experiential avoidance is with PTSD, you might avoid things that are external in the environment, right, that remind you of the traumatic event. But there are also these internal experiences, emotions, right? And I heard in one of the breakout sessions this morning, right, it was discussed how in some ways some of the military culture, and I would say broader culture of masculinity, reinforces this idea that we need to stuff down our emotions, not feel it. Unfortunately, what happens is with PTSD, that actually can set people up for developing PTSD, okay? And then this next ring here, the green ring, is the, this is at the interpersonal level. So this is when we're talking about things like social support, intimacy within relationships, and adjustment within couple-based relationships. We know that these factors, and I'm going to show you a slide in a minute to further make this point, we know these factors impact development of PTSD and recovery from PTSD, yet there's very few treatments that have been developed to target kind of this level of risk and recovery variables when it comes to addressing PTSD. And then finally, this kind of bigger circle is when we think about more cultural factors, cultural variables. So things like litigious and fault finding, right? So one of the things, the lessons that we often hear, both from religion, society, our parents, our teachers, is that children are taught the idea of good things happen to good people, bad things happen to bad people, okay? Not a bad lesson to teach a really young child, right? Because, you don't want your 4-year-old trying to comprehend, well, sometimes if you do bad things, you get away with it. No, they're not sophisticated enough to understand that. The problem when it comes to PTSD is that this tends to be something that we carry forward with us and that society reinforces, and that's not always true, that good things happen to good people all the time, bad things happen to bad people all the time, and then when something inconsistent with that happens, with that idea, that can make it hard for the individual to make sense of what happened, and they come away with these messages that are not helpful. We could also think about things like views on rape and incest in terms of how society views that, and responsibility, right? So sometimes you hear the term rape culture, right, discussed in terms of the idea that somehow the victim was asking for it by a way he, she, they dressed, and so forth. Things like ethnicity and stability of marriage and family. Now, interestingly, this is something that kind of intersects here with this green ring that we're talking about with regard to relationships. So for example, when we look at studies of Israeli veterans, we find that divorce rates of Israeli couples where one member is a military veteran is actually quite low, okay? Now, part of the reason for that may be it's in Israel is viewed as fairly culturally unacceptable to leave a military veteran, right? Whereas in the United States, we have higher rates of divorce. So certainly culture can impact this as well. This slide, I just want to make a point that this is research, 2 meta-analytic studies. For those of you who are not researchers, what that means is these are where they take a bunch of different studies that were done and they statistically summarize them to see, what the studies collectively can tell us. What these 2 meta-analytic studies did is they looked at, well, what are risk factors for PTSD, for development of PTSD? And as highlighted with the blue lines here, in each of these meta-analytic studies, one of the most potent predictors of whether or not someone develops PTSD or recovers from PTSD is social support, right? So having positive social support following a trauma may be protective, right? May be protective for a time. And probably even more importantly, having a lack of social support following a traumatic experience actually puts people at great risk for developing PTSD, okay? So this is important because when we think about, again, models of treatment, the models of treatment we have that have been most researched thus far are models that either focus at the biological level or that focus at the individual level, right? What a person's thinking about things, how the individual behaves. But there has been really a lack of development up until recently at interventions that fold in how can we use social support in terms of building social support as a way to help people to recover from traumatic experiences when those happen, right? And building that into a formal treatment. So when it comes to PTSD, so there was a meta-analytic study. Again, the meta-analytic term just means a study of studies by Casey Taft and colleagues, where they looked at 31 studies overall to examine, is there an association between PTSD and intimate partner relationship problems? And what they found is there in fact is a significant association, right? The more severe PTSD symptoms are, or the presence of PTSD is associated significantly with having relationship problems in terms of lower satisfaction in one's intimate partner relationship, and higher likelihood of violence in one's intimate partner relationship, okay? And the other thing to know about this research is that they actually found that these associations were stronger in the United States versus in other countries. So there could be some cultural elements to that, right? That if there's differences in the US between versus other countries. The other thing that's really important to what we're talking about today with veterans and military members, they found stronger relationships between PTSD and negative relational outcomes for military members and veterans versus civilians, okay? So what that tells us is there's even kind of a stronger effect, perhaps, of PTSD on relationships or relationships on PTSD for those in the military versus those who are not, okay? And I think it highlights the importance of really addressing relationships and relationship problems alongside of PTSD for our military members. Now, I'm not going to get into great detail in terms of talking about PTSD symptoms, but I will briefly kind of highlight that. So when we talk about the construct of PTSD, you might know generally what we're describing here. So there's some research that suggests that PTSD may fall into 4 symptom clusters. Now, those of you who are clinicians or researchers may notice that what I put up here kind of differs from what the DSM-5, which is how we do current diagnosis, what that tells us about PTSD. But this is based on research and not based on the DSM-5 committee's idea of what PTSD looks like. So the first thing to know, when we talk about PTSD, there's a set of symptoms of PTSD that we might call re-experiencing or intrusion symptoms. So these are symptoms where it's having nightmares about the traumatic event or events. Thinking about the traumatic event or events when you don't want to. It could go as far as having what are called flashbacks, where you're having experiences where it seems like you're back there at the time of the event, okay? So that's a hallmark symptom of PTSD, or a set of symptoms, I should say. Other symptoms of PTSD is that we also see with PTSD behavioral avoidance, right? So this often is people's way of trying to cope with the re-experiencing symptoms, right? So I'm having these unwanted memories. I'm being emotionally reminded when I'm exposed to things that remind me of the trauma. So one way I could try to cope with that is avoid, right? I'm not going to go to those places anymore. I'm not going to be around those people. I'm going to try to avoid thinking about it or having the emotions. Now, the dilemma with PTSD is that works in the short term. Unfortunately, in the long term, it doesn't work. And it actually makes the symptoms of re-experiencing even worse over time. Okay? So it's understandably a way to try to cope, but doesn't solve the problem. We also then have this set of symptoms that are symptoms that we might describe as emotional numbing. So that's where people who experience PTSD might describe that as I just feel emotionally flat, right? Like I'm in situations where I know I should be happy. I'm at a birthday party, I'm at, some happy family event, and I don't feel those emotions. I can't feel the happiness, and I know I should, right? Or even more disturbing, I know I should feel love toward my partner or my children, and I really have a hard time with that. So that can happen too, because possibly over time, if you're emotionally avoidant and you're really don't like these uncomfortable feelings that PTSD is bringing up for you, it feels out of control, you push away your emotions enough, you start to numb out, right? You start to not feel things over time. And then finally are these symptoms of what we call hyperarousal. So that's things like being hypervigilant, right? Perceiving that, situations you're in feel dangerous all the time, right? Having irritability and irritable and angry behaviors, having sleep problems, having concentration problems. It's basically the body in PTSD goes into this state of constant threat, right? And constantly being triggered by perceptions of threat, and it's chronic, and it's over time, and it starts to become indiscriminate. And so that becomes very problematic. So the way that this relates to a relational focused treatment intervention is the research clearly shows us, and there was a more recent meta-analysis by Erica Berkeley where they looked again at different studies on PTSD, and they found that really kind of the strongest component of PTSD that affects relationship satisfaction is emotional numbing, okay? Why do you think that is? Why would emotional numbing, out of all these symptoms, seem to matter most when it comes to relationships? Any guesses? Yeah, right? It's hard if you can't connect, right, and show somebody you care or feel that is really hard to stay in a very happy, healthy relationship. Really important. It's a very disturbing symptom when it comes to relationships. The other dilemma that we have when it comes to treatment for PTSD is even our best individual treatments, cognitive processing therapy, prolonged exposure, do a very poor job in addressing this. People can have really good improvements on all these other symptoms and still experience emotional numbing, okay? So there's a real hole there, I would say, from the treatments we've developed thus far that are individually focused to try to help out with both relationships and this particular set of PTSD symptoms. Now, when we talk about partner aggression or partner violence, which of these symptoms do you think is probably most connected to partner aggression or partner violence? Any guesses? Hyperarousal. Boy, you guys are good. You're guessing right all the time. Yes, hyperarousal. So intimate aggression is most connected to hyperarousal, which makes some sense, right? If we think about what are the symptoms that go along with hyperarousal, the symptoms are perceiving threat all the time. That could be in your interpersonal or intimate partner relationships, right? Both within and outside. Feeling threatened, feeling angry a lot, right? Having poor sleep. I don't know about you, but when my sleep's disrupted, I'm more grumpy, right? So I'm more likely to be irritable and, that sort of thing and act that way. So this is another area where PTSD symptoms and a different set of PTSD symptoms can really impact our intimate partner relationships. Okay, so again, we're going to talk about this model of treatment, cognitive behavioral conjoint therapy for PTSD. So this was developed starting in the early 2000s by Candace Monson and colleagues, and we're continuing to do research on it in different contexts and evolve this particular model of treatment. But Dr. Monson's idea was that, well, since we know social support and relationships are so connected to PTSD, maybe we should develop a model of treatment that has the option of involving concerned significant others into the treatment. And furthermore, maybe we could incorporate some of the interventions that we know work from individually focused treatment, but make it more focused on the couple, okay? And then we'll get into details of that shortly. So there are 3 uncontrolled studies. So the first was done among male Vietnam veterans and their wives, and this was kind of the earliest, I guess, iteration of this particular treatment, but showing that it seemed to be beneficial in reducing PTSD symptoms. Then there was a mixed uncontrolled study that was a pilot study, and then a little bit more recently we looked at with male veterans who were veterans of Operation Iraqi Freedom or Operation Enduring Freedom, who are male combat veterans and their wives, and showing that in that case also we saw significant reductions of PTSD symptoms. So some promising results. And then there has been one randomized controlled trial so far of this particular treatment. That was Monson and colleagues in 2012, published in Journal of the American Medical Association, JAMA, where they showed that PTSD was efficacious for reducing PTSD and improving relationship satisfaction. In addition to, if you read the article, one of the things that's impressive is it's also was shown to be efficacious for improving a wide range of other things, reducing depression, anxiety, in both partners as well. And in terms of PTSD, so as I mentioned, this the summary is that this particular approach seems efficacious and similar to our evidence-based individual treatments that we have with regard to its ability to reduce PTSD symptoms, okay? So they're right now, Monson's group is doing, and this is with the Strong Star initiative that's out of San Antonio. I think they're finished with the study, but they did a randomized controlled study comparing cognitive behavioral conjoint therapy to prolonged exposure therapy, which is a first-line individual treatment for PTSD. I'm not sure exactly what the results showed in terms of was one better than the other, but I know based on their preliminary data that was presented, they did find that the conjoint therapy led to significantly less dropout, okay? And this was among active duty military members. So now some of that, again, I think is probably the advantage of having that spouse or partner, right? Like, because people with PTSD, military veterans, military members with PTSD are often highly avoidant. I don't want to go to the treatment. You have a partner supporting them or in some cases saying, no, you're going to go. Come on, get in the car. Let's go to our appointment. Probably has some advantages there, okay? And then I mentioned with regard to partners' well-being, evidence that it may improve partners' well-being and relational functioning. The other thing I want to mention before we move on, so I mentioned that emotional numbing piece. There's a secondary analysis by Alex McDonald and colleagues of this randomized controlled trial that was based on the Monson study. And they looked at specifically, if we looked at the core symptoms of PTSD, including emotional numbing, did it help? And very promisingly, they actually found that for emotional numbing, there were large effect size reductions on emotional numbing with this treatment, which you usually, in individually based treatments, you usually don't see that, okay? So I think that is suggesting some real promise for couple-based, relationship-focused treatment to treat, the full range of PTSD symptoms, including emotional numbing. So one of the things I want to point out is that to do this model well, we always emphasize in trainings for this model, it's really important to engage in evidence-based assessment, okay? This is a cognitive behavioral model, similar to the model I talked about earlier this morning. Here, in some ways, assessing alcohol and drug outcomes is a little bit more straightforward because you're looking at, drinking, drug use behavior. With PTSD symptoms, we're having to rely on, clinicians kind of assessing what they think it is, or the person with PTSD reporting on their own symptoms, or the partner reporting on the person's symptoms. And so in each of those cases, though, it's important that we use really good evidence-based assessment tools to know, is this treatment effective for what we're trying to do, okay? And I'll say a couple points here about the assessment, is that the assessment usually happens in stages, and this would be the recommendation for delivering this treatment, that you would, as I talked about this morning, you wouldn't just jump right into this treatment with any couple that you're seeing. What you would want to do is start with an assessment, and the assessment might involve meeting with the couple first, getting some information about their background, right? Whether or not this seems like a fit for them. And some of the things we want to look for is things like stability in the relationship. Are they committed enough to stay together? This is a 15-week protocol to try to give it a go, right? Level of relationship violence. So we want to look at that, make sure that just like with this morning's talk, you don't have relationship violence that's so extreme that one partner, is at risk for serious injury or harm. I'll also say, similar to behavioral couples therapy, this treatment approach doesn't just exclude people who have partner violence that's not severe. In other words, you could include those couples because as I showed a couple of slides back, one of the things we see is that intimate partner violence risk relates to symptoms of PTSD, right? So the idea that if we could give the couple tools for better resolving conflict and to reduce their PTSD symptoms, that's going to reduce the risk of intimate partner violence. And then the other kind of criteria we're looking for is looking at, does one of the partners meet diagnosis for PTSD? Because this is a disorder-specific treatment. If there's not PTSD or at least some significant symptoms of PTSD, this particular treatment isn't going to be a fit. And I'll say I had that one time where a case that I saw at the VA of a veteran and his wife who came in, and they were evaluated, and it appeared they had PTSD. I didn't do the intake evaluation. And I'm describing the model to the veteran and his partner, and I said, does this make sense to you? And everybody else, who has PTSD that you described the model, they go, yeah, that makes sense. He goes, I really can't relate to that. So we had to go back and do an evaluation again, and it seemed that actually his main issue was depression, not PTSD. So I'm just bringing that up as an example of you wouldn't want to do a model like this that's really focused on PTSD where that's not the main issue. You would want to make sure that both partners don't have something like uncontrolled psychotic disorder or bipolar disorder, like manic bipolar disorder, where they're not going to be able to attend to the sessions, or an addiction issue that's so interfering that they can't come to sessions. Now, people with co-occurring addiction issues, this protocol can actually work quite well. As long as they can follow a couple of things and attend to a couple of things. First of all is attend appointments, right? Like if their addiction issue is so out of control, they're not showing up, well, the treatment's not going to work. Secondly, they got to show up not under the influence, right? And some people that have such a severe addiction issue, that's not going to, they may not be capable of that, so they need a higher level of care to address that issue. And the third requirement is that if you have a co-occurring addiction issue, whether it's a drug or alcohol issue, that they're able to engage in the out-of-session assignments and not be under the influence when they do that, okay? Because that's going to interfere with their ability to apply and learn the information, okay? So those are really the requirements. So we're meeting with the couple to assess that, looking at satisfaction, how do they resolve conflict, what is the risk of intimate partner violence. We want to look at things like intimacy and emotional expression, how does that happen, what is their sexual functioning within the relationship. And infidelity, I failed to mention that this morning, kind of an important thing for either protocol, so I regret I didn't even mention that this morning, but if you have ongoing infidelity in the relationship, this is something where actually couples kind of laugh at me when I tell them this, but I want to use, be evidence-based in my information I give them. I'll say that there was a study that was done, and this was in general cognitive behavioral conjoint therapy, where they looked at couples where there was no history of infidelity, couples where there was a history of infidelity, but the infidelity had ended prior to the couple counseling. And then there were couples where there was ongoing infidelity and that wasn't found out until the follow-up period. And I tell couples, guess what happened when there's ongoing infidelity and it's not revealed? Couple treatment doesn't work. And of course they go, well, no kidding. Well, I want to tell you that because if that's happening here, you're wasting your time. Like really, find a reason to not do this if you don't want to tell me, but don't engage in this. It's going to be a waste of time. And I should say in that case, couples where there was a history of infidelity, but it had ended, did have benefit from couple-based treatment. So that's the other thing to know. And then in this particular protocol, what we recommend doing is what's called a communication sample. So a communication sample is simply asking the couple to pick a mildly to moderately distressing topic, not on the high end of their list, okay, not their number one push-your-button issue, mildly to moderately conflictual topic, and I want the two of you to talk about it, and I, as a therapist, am going to just sit back and observe, okay? Now, why am I doing that? Well, I'm trying to get some behavioral understanding of what does your communication like, what does your conflict resolution strategy look like, and you might think, well, they're not going to argue in a way they would at home. But let me tell you, most couples they might think it's awkward at first, but once they get into it, they'll go, and you say, so how representative was that of how things go? They'll say, pretty spot on, right? Like they get into their argument or their conversation, and you tend to get a pretty good behavioral understanding of what their communication is like, okay? Now, in doing the communication sample, one of the things that you want to strategize is that you don't want to do that and then just say, okay, well, you just talked about a really hard topic and good luck, and I'll see you again in a week. So ideally what I like to do is I like to pair doing the communication sample with when they come in for the first session of the treatment, and then I have them do the communication sample first, and then we go into session 1 protocol, because then that way I'm giving them a chance to de-escalate, to give them some skills and some hope that we're going to improve, okay? And then in CBCT, we like charts and graphs and data. Now, actually, I think it's really helpful, and I think couples like to see this, right? I mean, my couples where I'm showing them each week, here's what your self-rated symptoms are. And what this shows is there's kind of 2 elements of this. At the top here is what are called PCL scores. So that's like the PTSD symptom checklist or PTSD checklist scores, which are self-rated PTSD scores. And what we get here in terms of tracking progress over the course of the treatment is we get a rating for both the partner's rating of the person's PTSD. So this is how I see your PTSD symptoms. And then we also get the person who has PTSD rating his or her own symptoms, okay? And this can be very interesting and informative data, because oftentimes at the beginning of treatment, you might see wider disagreement. And then over the course of treatment, they start to become more in line with how they're seeing the symptoms. And that actually can be in and of itself some evidence of treatment progress, right? Because what that often results from is we've identified the symptoms, we recognize them, we're starting to talk about them and not avoid. And that could be a good thing. The other thing, of course, we want a trajectory that looks like this, right? Where symptoms are going down, okay? If symptoms are not going down, then it's a good point of discussion, right? That's the advantage of doing evidence-based evaluation. You can have a discussion about it. You could see, what's going on. I had a couple that I did this protocol with, and it was a very clear pattern. When they would do their homework, their symptoms would go down. Then they'd have a week of not doing their homework, and guess what? The PTSD symptoms would come up. Then they would do their homework. And I said to them, I said, well, the good thing is you guys did your own study. You did what's called an ABA design, where you didn't do the intervention, you did the intervention, you didn't do. So what we could clearly say is when you do the skills, it improves your PTSD symptoms, it improves your relationship satisfaction. When you don't, the opposite happens. And that actually was quite helpful for them. Like once we saw that pattern, they were then very good about doing the out-of-session assignments and had really good improvement in the treatment. The other element that we're trying to track is relationship happiness. And the way you do this is there's a version of the PTSD checklist that's been modified for this particular treatment protocol that has just a 1-item happiness rating that's from 0 to 6. 0 would be, like the most unhappy you could get. 6 is perfect. Now, 6, I also wonder if there's something wrong with the relationship. You're saying it's perfect, but anyhow. We generally want it to be higher, and we want to track that to see is the relationship satisfaction improving. And I should say this 1 item in terms of its correlation with scales that have multiple items on it is really quite high. It gives us a really good quick indicator each week of where their symptoms are. Okay? So that's something that in the protocol, we assess and we track the symptoms every week. Okay? We should be tracking it on a weekly basis to see are there improvements, or in this case, bi-weekly, I guess. I do it weekly, but. All right. So overview of cognitive behavioral conjoint therapy for PTSD. So it is it's a frontline treatment for PTSD, okay? So this is something we would consider that if you want to do this instead of doing prolonged exposure therapy or cognitive processing therapy and try this first, it's built for that, okay? It is built to be a first-line treatment. Secondly, it's trauma-focused but not imaginal exposure-based. So let me explain what we mean by that. Imaginal exposure, so that's a component of a very highly effective treatment called prolonged exposure therapy. The imaginal exposure piece involves doing exercises where rather than pushing away the memory and the emotions, we're going to, in a very safe, structured way, face those memories and emotions. You're going to do that with your therapist. And you're going to do that by going through all of the details of the trauma and actually closing your eyes and talking through what that traumatic memory was. And then you're going to repeat it again and again and again. And it's based on what's called a habituation model, which is the idea, and based on science, we know, the more that we face something that's anxiety-provoking over time, assuming it's not an imminently dangerous situation, your anxiety is going to decrease, okay? This particular, now, I'll also say that's one of the things where some veterans and military members are like, to heck with that, I'm not doing that, right? No way, all right? I would prefer a treatment that did not involve that, okay? Well, if that's the case, then good news. We have treatments that do not involve that. This is a treatment like that. So it's trauma-focused, meaning we are focusing on PTSD symptoms, and we're focusing on how have you made sense of the traumatic events. So in order to talk about that, we do not have to go through all of the fine-grained details of the trauma, right? Like point by point, okay? We don't need that. We just need what we might describe as, kind of a 1,000-foot overview. If you're looking down from 1,000 feet, like I kind of generally see what's going on. I don't need to know all the details of it. That's the level of detail we need. So some disclosure, and it's not repeated. It's not like we're going back through the imaginal, the memory of the event over and over and over, okay? But we will discuss it, and we will discuss how have you made meaning of it, how has your partner made meaning of what's happened, and that's a very important element. It is a 15-session manualized protocol. Sessions are about an hour and a quarter, so about 75 minutes. I mentioned the inclusionary-exclusionary criteria. Now, the most evidence exists for partners, for let's say in this case, the military member having PTSD and the partner not. But clinically, I know those of us who use this routinely, guess what? Clinically, you encounter very commonly couples where one person has PTSD and lo and behold, the other person does as well. And so in that case, we've done adaptations of protocol where you address both people's PTSD symptoms simultaneously, okay? And so the protocol is flexible for that, but just know that, the controlled studies that have been done have not included, partners where couples where both members have PTSD. Okay. And then I already mentioned the partner violence criteria. Minimal commitment, again, can you try to make it through the 15 weeks? And do you have, just like with behavioral couples therapy, do you have the ability to have daily contact with your partner? Easiest to do if they're married or living together, but we want to have daily contact as a requirement. Okay, so some other basic assumptions about the model. That the significant other may have a problem, right? So that could be due to what's called assortative mating, right? Like where it's like, okay, well, you don't like to talk about difficult emotions and neither do I, and so that fits. Let's avoid together, right? Or, you don't like to go out and I'm kind of an introvert and so we'll just never go out, okay? The other thing is, too, illness burden is a real thing, right? So that's something where it's like, the effects of the partner on their mental health of living with the PTSD as well. And then we assume a reciprocal association between the relationship problems and the PTSD. This is basically the identical model to what I presented this morning, except just replace substance use disorders with PTSD. Okay, and then we have a little graphic to show you that. All right. And then that there's a systemic association in terms of system-symptom fit, right? The idea being that PTSD kind of works its way into a relationship, and the relationship accommodates to that. Well, how might that work? An example might be, okay, you have a hard time going out. I'm going to do all the grocery shopping all the time, right? You're never going to go to the grocery store, so we're accommodating, right? It's hard for you to go to family functions, so I'll just tell them, similar to like substance use, right? Like I'll just tell them you're sick, you can't come, you're not feeling well, so you're going to avoid not do that. Okay, so the relationship accommodates to it. And so what we want to do is help teach both partners skills for how do you not continue to accommodate, how do you face and address and reduce PTSD together. So we look at CBCT for PTSD in terms of 3 stages. Phase 1 involves introduction. We provide psychoeducation about PTSD. A couple I'm seeing right now, they said to me, that was so helpful, because they didn't understand PTSD, and they said, boy, it's like now that we can see the enemy, and we know who the enemy is, and now we can, we can have a plan for battling it, right? But until you know who your enemy is, it's hard to face it. Phase 1 also involves safety building, right? Making sure both there's emotional and physical safety in the relationship. Then phase 2 builds on phase 1 in that we're introducing skills to enhance relationships. Now, guess what? A lot of these skills to enhance the relationship are the same things that we talked about this morning. Now, the goals are a little bit different, but functionally, they're kind of similar strategies. In addition, we're working on undermining avoidance. One of the things we know about PTSD, and we talked to couples about this, is that avoidance really can prolong PTSD symptoms. I'll talk about that a little bit more momentarily. And then finally, phase 3, and this is unique to this model of treatment, is dyadic cognitive intervention. Ooh, what's that mean? That means both partners looking at thoughts they're having about the trauma, about PTSD, and helping each other out in terms of checking those thoughts, and are those balanced, and are there other ways to look at it? So a team-based approach to that. Okay, so phase 1, I mentioned introduction to treatment. So this is where we're teaching couples to understand PTSD in an interpersonal context, all right? So it's not just about understanding PTSD symptoms, but we give them information. Here's what PTSD symptoms look like. Tell me about, in your relationship, how do you see intrusive or re-experiencing symptoms? How do those show up, right? And then they talk about it. For your relationship, how does the avoidance show up, right? And oftentimes it's both partners have perspectives on this and behaviors that relate to PTSD. The other thing we want to make clear is that we understand in this model, and this is backed by research, that PTSD we can consider to be a disorder of impeded recovery. Well, what do we mean by that? What we mean by that is if we look at research on individuals following traumatic events, what the research tells us is that most people following a traumatic event have symptoms that we would describe as resembling PTSD. They might have, in the weeks or days or weeks after the trauma, things like nightmares, feeling on edge, feeling a little irritable, sleep problems. The thing is, fortunately for most individuals, those symptoms decrease over time, okay? For most individuals that happen. For people with PTSD, it doesn't. Those symptoms elevate and they just stay. So what does that tell us? Well, what that tells us is something is getting in the way of recovery, okay? It's a disorder of impeded recovery. Something is a barrier getting in the way of that. So what we want to do, and we really theoretically look at kind of 2 main things that are barriers. One is avoidance, right? Because if I kind of avoid everything, I'm never able to get sort of corrective experiences to know, in fact, I can handle my emotions, or, my anxiety will go down over time, if I'm always avoiding. So we want to address avoidance and then also meaning making. So the research is very clear when it comes to PTSD that certain ways of looking at traumatic events tend to set people up for PTSD. Things like, it was totally my fault, and I'm to blame for it, and and then PTSD starts to affect the way we view the world, right? The world's completely unsafe, you can't trust anyone, this sort of thing. And what we know from psychotherapeutic research is that if we start to effectively address ways that we've made sense of the trauma, that we're seeing the world, and start to have more balanced views, PTSD symptoms start to decline, okay? So those are the two main kind of strategies or targets for addressing PTSD, okay? And then treatment contracting is part of this as well, right? We want the couple to be on board, to understand the expectations of the treatment, and to develop some goals, right? Now, this is not unique to this, right? Anybody in in treatment, in any form of treatment, you're going to have a treatment plan, and you're going to want the couple to tell you, so, what would that look like for you if we knew PTSD was decreasing, right? What would be important to you as a couple? And couples might say all kinds of things in terms of what their treatment goals might be. Well, we'd see less anger, right? Or I'd have nightmares go down, so I'm not having them every night, right? And then in addition to the PTSD, we want them to think about, how would you like to see your relationship improve? Common examples might be, well, we'd like to communicate better. Okay, well, what would that look like for you? If I were to observe you, how would I know you're communicating better? What behaviors would I see that are different? And then two things we introduce after session one. First of all is catch each other doing something nice. Sound familiar? Hopefully it does, because I talked about this morning, right? Common thread here. Okay, now, the common thread is that we're using this to improve relationship satisfaction, just like I talked about in the morning. In a PTSD-focused treatment, this has an additional sort of, I guess, sneaky advantage to it, okay? We talked about emotional numbing, right? One of the things that PTSD tends to make people do is, I have a hard time feeling emotions, even positive emotions, and I want to avoid kind of even any interactions that might bring about any sort of emotional experience. So this is a real nice, sneaky way almost to start using the relationship and using this catch your partner exercise to promote just some positive exchanges and emotions to start to shrink that down, both in terms of the avoidance and the emotional numbing. So that's the additional strategy here we're using. And we're starting off with something that's like, this is a pleasant, fairly easy activity, right? We're not jumping into something that's, really incredibly hard to begin with, right? This is kind of easing into the treatment. And then we have each partner respond to what we call trauma impact questions, okay? And these are some standard questions that we ask them to answer in the treatment, and I think I have a slide on this. If I don't, I'll go back to it. But we give them this graph, too, in terms of explaining the rationale for the treatment, okay? We go through and we talk to them about PTSD symptoms, what the re-experiencing symptoms are, what do you notice as re-experiencing symptoms, and then sort of graphically what we're explaining is, what we sometimes see that happens is that re-experiencing symptoms then leads people to feel on edge all the time, right? Increases the hyperarousal. Then as a way to deal with the hyperarousal, as the arrow's pointing down, we see to avoidance and emotional numbing. So people engage in avoidance, couples engage in avoidance and emotional numbing. It's a way to try to deal with that. The problem with that is that then in turn increases re-experiencing or intrusive symptoms. It doesn't solve the problem. It actually makes them worse over time. Right? So it's this cycle, it's this dilemma. So what we are going to do is we are going to give you ways to cut off that. I'm going to give you strategies, okay? So we stop this cycle and so that the PTSD symptoms decline. And I mentioned the disorder of impeded recovery. We also present this graph to them, right? And this shows two very distinct trajectories. Here's what tends to look like as an example for people with PTSD in the weeks following the trauma, right? And this just continues, right? This flat line where it's just really a lack of recovery. And then for people who don't develop PTSD, notice they have some of these symptoms at the beginning, but over the weeks following the trauma, those symptoms decline, right? So this is telling us what's the difference here. Something is getting in the way for this group up here who has PTSD in terms of the recovery. And so we're going to give you skills to get unstuck from your recovery in this model. And this is the trauma impact questions. So a couple questions. Both partners answer this, and they answered independently. So the first question is, how has trauma or PTSD affected our relationship to date? How has it impacted my thoughts, feelings, and behaviors about our relationship? Okay, each partner answers that separately. And then secondly, why did the traumatic events happen to me or my partner? Well, what are we trying to get at there? How have you made sense of it? Who do you blame? Right? Who's at fault? Do you think that you could have done something, you or your partner could have done something different and prevented it? Okay? These are all to identify what are some of the problematic ways of thinking about the trauma that may be underlying some of your PTSD symptoms. And then we have them answer in a couple of areas. What do I believe as it relates to trust, control, emotional closeness, and physical closeness? Now, the reason these are chosen, these are common themes that are often impacted by PTSD, right? That people have problems with trust, or couples have problems with trust. And that could be both partners. By the way, the couple I was mentioning, it wasn't just the partner with PTSD, right? He has problems trusting other people. She has problems trusting him in terms of how he'll react. So that's a trust issue as well. Control, right? Like how well do I control myself, my own emotions? How much do I need to control other people? That can be greatly impacted by trauma. And then emotional closeness and also physical closeness. And physical closeness, by the way, it could be sexual, but it doesn't have to be sexual, right? Like the people with PTSD, they might have a hard time hugging their kids, right? Because they had a trauma that maybe involved children, and it's a reminder, right? So physical closeness could be impacted in a variety of ways. Okay, and then safety building in session 2. So we talk about things like disclosure, right? So one of the things to know is with PTSD, oftentimes, and a risk factor for development of PTSD is that someone has tried to disclose their trauma, often early on, and been shamed for it, right? Like I tried to disclose it to you, and you, like somebody told me, like, well, that's your fault. Like, why did you do that? Or reacted in a way that was not supportive. Okay, so we want to explore, have you told anybody about this before? How did they respond, right? Have the two of you talked about it? Do you have concerns about what it would involve if you talked about it? Okay, so we want to know all of that up front and send the message of, we're going to make this a safe space and this a productive space and talk about this in a way that's going to be helpful and not harmful. And then we talk about negative behavior. So this is things like physical violence, and it's also things that like, being emotionally or psychologically aggressive, right? Name calling or threatening to leave your partner, things like that. These are behaviors that can relate to PTSD, but that we want to reduce, we want to eliminate. And foundationally, this is important because if the treatment's going to be effective, it's got to be a safe space. And then we teach them both primary and secondary prevention strategies. So the primary prevention strategies involve things like diaphragmatic breathing, right? So that's something individually you can use. I'm starting to get worked up. I'm going to slow down by breathing to kind of put the brakes on that physiological response, okay? And then timeout. So I talked about timeout earlier. Same thing here. We teach couple timeout as a safety strategy. And then in session 2, they're continuing catch your partner doing something nice. They're learning about their anger, and they're practicing timeout. Okay. This manual has a nice sheet for timeout, right? And it has, in this case, what their assignment is, each partner practices calling a timeout one time, okay? what we tell the couples is don't provoke an argument, though. Like, practice calling a timeout if it's kind of mildly irritating and just say, no, I'm practicing a timeout. Or just mock call a timeout. Like, I'm not angry, but I'm going to practice calling it because you're going to perhaps need it at some point. Okay, so phase 2, this is where we get into a variety of topics that focus on improving communication and also starting ways of trying to approach rather than avoid, and then finishing this off with kind of some of the cognitive strategies and problem solving. Okay. So one of the exercises we have them do is a communication exercise, okay? And we have them do a communication session in the therapy session with each partner responding to the following question. And by the way, when I say communication session, it's like I was talking about this morning. They're talking to each other. As a therapist, if they start talking to me, I'll say, talk to your partner. Tell your partner about it. Look at them. Look at them in the eyes. And they take turns, right? So the person who is the listener is supposed to just reflect. What I understand that you're saying is, whatever they said. And then they switch. So the first question we give them is, what kinds of things would you stop avoiding if you shrunk the role of PTSD in your relationship? Okay? So PTSD specific topic, right? We're having them start to talk about the PTSD. We're using this to both model and focus on communication skills, but start to develop a list of things that they avoid as a couple. And I'm going to show you what the list looks like here in a minute. Once they're done with that, we then ask them to talk to each other about how can you imagine feeling if you shrunk the role of PTSD in your relationship? Now, I really like that follow-up question because I think what we're doing here is helping them to think about what would the future look like if this were to improve, right? And people have a hard time struggling with even imagining that or getting a sense of hope around PTSD ever improving or their relationship improving, okay? And then we end by helping them to develop and plan for a couple level, what we call in vivo approach, okay? Well, what is one way that we start to practice reducing avoidance? By approaching and not avoiding. But we do that in a very structured way, right? So we're doing that in a way where we coach the couple that, first of all, your anxiety, you don't want to leave the situation when your anxiety peaks. That actually just reinforces the anxiety, makes it worse, the next time. Stay in it for a sufficient period of time and do your best. And that you got to repeat it. It's not going to, this isn't a miracle cure where you're going to go, well, the first time I did it, I felt better. No, it's got to be repeated. Okay? And over time, it'll start to get easier. Over time, the anxiety will decrease. And then, so we assign them USAs, or out-of-session assignments, shorthand for that, and then checkout. Now, I really like the checkout, too. The checkout is, each of you tell me one thing you're taking away from today. Now, I'm often surprised, right? Well, I thought, such and such was really impactful. Oh, wow, okay, we talked about that for 1 minute, but if that's what you're taking away, okay. But that can help consolidate the information, also for you to check in as a therapist, what's helpful, what's not. So this is what we call their avoidance list, right? So based on this conversation, we're starting to develop a list of places, situations, people, feelings that they avoid. And we're going to start to plan for strategically how do we start to develop some approach exercises. Now, that could be very systematic and you can work your way up. So an example might be, a couple I saw where avoiding malls because of the crowds was a thing, right? Like that was the partner with PTSD, he just was like, I can't do it, I get too overwhelmed. And by the way, I'll tell couples, I'll say, now, if you get a situation where, I hate shopping and I hate going to Walmart, and it's not because I get anxious, I just dislike it, If you start making decisions about, based on your own choice, not PTSD driving the bus, I'm good with that. But for now, we got to start with, let's do some approach exercises to break the PTSD. So they started with, well, let's go to the mall when it's not busy, like on a Tuesday morning, and we're going to go together, right? And we'll spend some time there. And then next, we'll practice that a couple times. Now we're going to go when it's a little bit busier, maybe like Friday night, okay? Next, we're going to go when it's really, really busy, and we're going to practice that a couple times. Next, he's going to go, and I'm going to stay home. Now, you might think, how is that a couple-based strategy? Well, it's still addressing PTSD together. It's now the partner saying, I'm going to back up, and you can do it. You can do it yourself, right? And I'm going to give you an opportunity for that, because that affects their relationship still, right? And then that strategy's continued throughout. You keep doing the approach exercises throughout. This, by the way, was a strategy that was adapted from prolonged exposure therapy, but it has a very couple-based element to it, right? It's the partners teaming up. Then I want to talk a little bit about kind of how do people change their minds, okay? So this is setting us up for the cognitive component of this intervention, all right? So a quick historical summary of the research on cognitive therapy and how we understand how people change their minds. So we used to think a long time ago that it was this thought replacement. You replace a bad thought with a good thought, that fixes the problem, right? The bad thought's gone, okay? And then this idea of thought restructuring came along, right? Like, we're not replacing the bad thought, we're modifying it, right? That bad thought becomes from, the world's completely dangerous to, some places are dangerous, but, most places are safe or something. And that becomes my thought, and that thought is restructured. What we know from modern neuroscience and cognitive research is that kind of both of those don't really describe what actually happens when we change our mind. When we change our mind, those thoughts tend to remain in our head, right? We still have those old thoughts. And if we look at it both a very brain-based neurological level, it's, we have these neurological connections that don't go away. But what can happen is we start to develop competing thoughts, other ways to look at it. We start practicing those competing thoughts, and those competing thoughts become stronger and stronger and easier to kind of go that route rather than the old way of thinking, right? Think of it if you're driving over terrain and you've driven over the same terrain over and over and over again. It gets, these ruts get worn into the terrain. It's hard to kind of get off and develop another path. But once you start developing that other path, then we start wearing down a different way of going, right? A different direction. So that's an analogy to think about. So what we're trying to promote is cognitive flexibility, right? Ability to consider multiple perspectives and make kind of choices, and then start to practice what we think are the most balanced and helpful choices. And then this kind of raised the question for, if you look at traditional cognitive therapy, they use all these complicated worksheets with all these columns. It can be helpful, and I use that in some individual therapy, but do we really need all that? Right? Do we really need to go in painstaking detail being like, well, this is why my thought was wrong because I did this 18-column worksheet and it tells me, that really wasn't a good way of thinking about it. Perhaps not. And so in CBCT, we can use the relationship in a very adaptive way. One of the most important roles that our relationships play and our partners play is reality testing, right? Like, to go home to your partner and say, help me, this thing happened at work. Am I thinking about this the right way? And they give you a different perspective, right? That reality testing, it's a real advantage. And so what we're doing is teaching the couple to use the strength of their relationship to help each other out to test thoughts, okay? It's a process rather than using this 18-column worksheet. And we're also teaching them approach in terms of being non-judgmental, right? Like, be open, be non-judgmental. A thought doesn't define you. And, let's kind of just be helping each other out as teammates in looking at your thoughts. So we teach them this process we call the unstuck process. And here's the acronym. So being unified as a team, Next, notice what your thoughts and feelings are. That can be hard. Take some practice to do that, even. And your partners can help out. S is brainstorm. This is why it falls a little flat, but go with us. Brainstorm alternative thoughts, right? What are other ways to look at it? Table test the thoughts. What we mean by that, and I'll show you the worksheet we use, but it's literally on a worksheet writing all these different options, putting it out on the table, and really table testing in terms of like, what is the evidence for that? Or does that really make sense? Is that the most helpful thought, right? Having kind of a discussion about these different options. Then selecting and using the most balanced thought or thoughts. Could be more than one. I have couples that sometimes will go, well, I think this one and this one both fit. And I think they're both helpful. Great, okay, those are the best thoughts. Let's use them. Noticing if I saw things from the different perspective, so let's say using the most balanced thought or thoughts, how would that change my emotions? How would I feel differently? How would I behave differently? Okay? And then, very importantly, how do you keep practicing it? Because there's very few times where you go through this and go, oh my gosh, I never thought that way. My life has changed, like my PTSD is fixed. Doesn't usually happen that way. It'd be great if it did. But usually, to change long-standing patterns of thinking, it requires practice. How are you going to keep practicing it? What are you going to do? So this is the very fancy worksheet we came up with. It's a worksheet with a circle and some lines down there. So it's not an 18-column worksheet, okay? It's simplified, but notice that it has the unstuck process for the couple. And we teach them in session, here's how you do this. Here's how you go through this process. And so I'm going to give you an example. And this is actually this exact thought is a thought from a veteran couple that I saw. So to distill it down, so they're unified and curious, and then noticing the thought. The thought that they identified was the partner with PTSD he was having the thought, if I am in control of my surroundings, then there are no surprises, right? Surprises are bad, there's no surrender. If I'm always in control, things are great, okay? So then they brainstormed. These are the thoughts they came up with. Having to be in control is a tiring process, so that's another way to look at it. Cannot control outside influences, okay? That's another one. By the way, either partner can nominate thoughts in this process, right? Might be the male veteran partner's thoughts, but his female partner might go, what about this one? Okay, well, let's take a look at that. Surprises can be a good thing, like his 30th birthday. I think she came up with that one. She's, remember your surprise birthday party? You liked that. He's like, oh, yeah. Causes too much stress. And then just because I think I'm in control doesn't mean I'm in control, right? Kind of telling myself a lie here. So that's the one they chose. And so nothing fancy. This is the way we do it. We just say circle the thought or star the thought you think's the best. So that's the one they thought was the most helpful and most balanced. And then below, under C, this is how does this change emotion or behavior? So he determined if I could tell myself this, just because I think I'm in control doesn't mean I'm in control, I'm going to feel more relaxed, I'm going to feel calmer, I might take more risks in a good way, okay? And then, so finally, K, keep practicing. What are we going to do? Well, read the worksheet every day, review it, get it out, look at it. And that for his partner to kindly remind him of the other way of looking at it, not, why are you thinking that way? But, hey, remember we went through the worksheet and, just because you think you're in control doesn't mean you are. Oh, yeah, Okay, so that's the unstuck process. And then a couple things here I'll just highlight in wrapping up. So stage 3, we're using the unstuck process to develop many themes that go along with PTSD and recovery from PTSD. Acceptance, blame, trust, power and control, emotional closeness, physical, closeness, and post-traumatic growth, okay? So these are all themes that come up. And the only difference in the session is the topic that you're focused on, right? Like session 8 focused on acceptance, session 9 focused on blame. You're continuing the in vivo exposure throughout, and you continue some of these relationship-focused strategies, using good communication skills, catch your partner, that sort of thing. Okay, another quick example. I could have chosen not to fire my weapon at short range. Okay, so here's another unstuck process. You can see here. And then in this case, they chose all things considered. I used my best judgment and made the decision given to me. Okay, and then the change would be less guilt, less sense of individual responsibility, more confidence that I made the right choice, etc. Okay, and then how can you keep practicing? Often reminding myself I made the right decision. Read over the sheet with my partner. Okay. Okay, so I'm going to finish with wrap up a couple of points here. We also could think about significant other level involvement in PTSD treatment generally. All right, so and there's a continuum here, none to max. Okay, so let's say somebody wants to do other evidence-based individual treatment, cognitive processing therapy, prolonged exposure therapy. It still would be viable actually to do phase 1 of this treatment. Okay, right? You could still bring in a partner, educate them about PTSD, and talk about safety. Nothing wrong with that. Doesn't conflict with individual treatment. What if there's either relational distress or accommodation? What I mean by accommodation, different term from what we used this morning. This morning we used enabling. Same thing here. It's sort of you're accommodating to the PTSD. Okay. Well, in that case, phase 2 might make sense, where we're teaching communication and approach. Okay? Kind of questionable if you would do other evidence-based PTSD treatment in that scenario. Might be too much, honestly. Okay? And by phase 3, it's that's where we're really focusing on trauma processing. And so, if we're going to focus on trauma processing, then you definitely do not want to do other forms of treatment. It's going to be too much and too confusing for the individual. Okay? So I'll just put up here some resources for those interested in learning more about this treatment. You can go to this website, and there's opportunities for training. There's also a couple of good books. This book is a chapter book, and it talks about conjoint therapy for PTSD. It also talks about behavioral couples therapy for substance use disorders, and a number of other good evidence-based strategies for military members and veterans. So it's a good resource book. Gives good examples of how to do it. And then the manual for this particular treatment is this manual here. Has reproducible handouts, I think well written and well structured. And with that, I will stop and take your questions. What do you do if you're moving through the protocol and it's kind of either they're not getting it or something's getting in the way? Well, a couple things. Number one is kind of asking about that. What got in the way this week? Maybe sometimes it's practical. Busy week, kid was sick, I was sick. Well, in that case, no big deal. Let's assign it again and let's try again, right? If they didn't do any of the out-of-session assignments, I wouldn't move forward with the protocol. It doesn't make sense. If they did some and it's your clinical judgment where you think like they mostly got it, then maybe you could move forward. I tell couples, I generally have a rule. If there's like 2 sessions in a row where you haven't done the treatment, we're going to have a serious conversation about, is this the right treatment for you right now? Because I do not want couples going through this treatment and things are getting in the way and they're not doing the intervention, they're not practicing the skills outside, and then you get to the end and go, well, that didn't work. And it could just be a matter of timing, or it's just, now's not the right time, too much going on. Better that we pause and come back to it later on when, maybe that issue's more resolved. Doesn't have a wife that's a good question. Now, we saw a case, this can be modified, somebody has a concerned significant other that's not a spouse or partner. In the clinic where I worked, we saw a case in the VA, veteran and another family member, and he wanted this other family member involved, right? And we saw another one that was a veteran and his brother. That's okay. I mean, obviously there's some adaptation of that, so it can be done, if somebody has a concerned significant other, and that's not always the case, right? I'll say the good thing is we still have these other treatments that are individually focused treatments that in that scenario where it's like, well, there's not anybody I want to involve or anybody that I'm able to involve, we can try a different approach.